Welcome everybody, and Glenn, I will hand it over to you if you want to take control of the screen.
Great. Good evening, everyone. Thanks for coming along tonight. It's always tough after a long day at work to front up for talks, but we appreciate you coming along. And tonight we were going to have a little chat about, so I'm just getting my screen up, the non-operative management of osteoarthritis of the hip, knee and shoulder. Now, I thought it was fairly relevant for you guys because everyone sort of knows that the end stage or the end game for end stage osteoarthritis is joint replacement surgery, and that's we take over when it gets to that stage. But for most people with osteoarthritis, their journey is much longer prior to seeing an orthopedic surgeon, and to optimize their management through that journey and manage their symptoms and improve their quality of life is really the realm of primary care physicians like yourselves. So I thought probably talking about this aspect of arthritis management rather than joint replacement surgery, etc., was a little more relevant to you all. So we'll just start with a few basics, which I'm sure you're all well aware of. So osteoarthritis is a chronic, progressive and degenerative condition. It's by far the most common form of all the arthritides in our community. It affects a lot of people, so 10% of the total population. And if you think, on a global scale, that there's, say, 8 billion people in the world, that means there's 800 million people at any one time affected by osteoarthritis. And obviously those figures go up with advancing age. So the statistics would show that 20% of people over 45 and about a third of patients over 75 have symptomatic osteoarthritis that affects their day-to-day functioning and quality of life. There's no cure, so we don't have any really good disease-modifying non-surgical modalities. Obviously, there are things like stem cells and those sort of regenerative techniques that are still in essentially experimental phases, but there's been nothing that's really shown good evidence in clinical trials to regenerate cartilage tissue, either in vitro or in vivo, and certainly not in vivo in a patient population. So that said, it's not rocket science. Really, all treatments for arthritis are essentially aimed at pain relief. And by relieving pain, we then see the flow on into improvements in function and quality of life. But it's really just through simply getting rid of people's pain that we see their quality of life and function improve. And the prevalence of osteoarthritis is going up and up, and that's predominantly a function of its relationship to two main factors, and they are advancing age and obesity. And they're both factors that are going up and up in our society. So people are living longer because we're doing better from a general medical point of view, and we're managing chronic illness better than we've ever done. So that's letting people live longer. And we all know, particularly in our community up here, about the current obesity epidemic that's going on. So there's a huge economic burden from osteoarthritis. From a direct cost point of view, the statistics from 2015 and 2016 showed that direct cost from the Australian health purse to osteoarthritis was $3.75 billion in that year. That's over 3% of the total health budget. 30 to 40% of this was medication costs. So that's roughly $2 billion a year going purely to fund medications for people to manage their chronic osteoarthritis. If you're adding the indirect costs from osteoarthritis, such as time away from work, etc., it costs our community over $23 billion in that same timeframe. And on that topic, it's a leading cause of early retirement. And I certainly see plenty of patients in my practice, and I'm sure you guys do too, who just get to the point in their late 50s, early 60s, where they don't really want to stop work, but their arthritis becomes so symptomatic that they just find it a struggle. And because they're heading towards that retirement age anyway, they pull the pin earlier than they would like because of their arthritic symptoms. On that note, 50% of patients aged between 45 and 64 are unemployed, and that's twice the unemployment rate of the same patient population or the same age group who don't have osteoarthritis. So in very broad terms, when it comes to osteoarthritis management, we can talk about it as operative and non-operative. And then under the non-operative umbrella, broadly, we often categorize treatment modalities into pharmacological and non-pharmacological. So pretty much the talk tonight is going to focus on non-operative management, so both pharmacological and non-pharmacological treatment modalities. We're going to talk about what the options are, and most importantly, what's the current evidence for these options, because look, and after doing some literature research to compile this talk, I mean, things have changed since I last looked at it, and some of the guidelines have changed and the recommendations and first-line treatments and the evidences have changed. So things that maybe had some better evidence 10 years ago, maybe we've sort of re-looked at that evidence now and we've found, well, the recent evidence doesn't support that. And maybe in retrospect, the evidence that we were basing those guidelines off maybe wasn't as good a quality as we thought. So we'll start with the pharmacological treatments and we'll work around the sort of basic things first. So paracetamol, traditionally, we've all been sort of told this is first line. And I must admit, I sort of tend to still use it first line, and probably until I did the literature research for this talk, it was still my first line, but it probably won't be after this because some of the data has changed. The previous data has fairly broadly always suggested that there is a small to moderate effect. It's never been a panacea to curing osteoarthritis, but we've generally had a fairly good consensus that in early disease, it does improve symptoms, and it should be your first line because of its good side effect profile. And that's really what makes it so appealing, is it's a very safe medication taken at the appropriate dose, and it can be taken for a chronic period of time with little to no side effects at the right dose. The recent data, however, is probably not as supportive as what the previous data was that we were basing all of this on. And so there was a Cochrane review in 2019, and there was also a meta-analysis published in The Lancet in 2017, and both of which questioned the effectiveness of paracetamol and really questioned that current guideline of paracetamol as a first-line medication. And so I think based on that literature, Cochrane reviews and meta-analyses are usually fairly compelling level 1 evidence, and they would suggest that probably paracetamol is not as effective as we've always thought. So that moves us on to non-steroidal anti-inflammatories, which in my practice, I've always used as more of a second line agent, and always, I don't like using them in patients for more than a couple of weeks at a time. And it's because primarily most of these patients have medical comorbidities, and we all know about the renal and GI side effects of chronic non-steroidal anti-inflammatory use. And then probably a little more contentious, but still thereabouts, is the cardiovascular effects or the potential cardiovascular effects of the COX-2 selective medications. So generally, I try and steer my patients away from using NSAIDs, for more than just bursts of 2 weeks. And I generally try and keep them using the NSAIDs for an acute flare-up, or if they're going to do something where they know they're going to flare up their symptoms. If they're going on a holiday and they're going to be walking more, I say, look, okay, just take some anti-inflammatories with you and just take them every day prophylactically, because it's likely with your increased activity level that you'll get increased symptoms. So all of the studies pretty much show a good effect. Now, most of the data we're going to talk about tonight is hip and knee data, primarily because they're the most common joints that are affected with osteoarthritis, being the weight-bearing joints. But I think it's fair to extrapolate that data to other joints, particularly the shoulder, not as commonly seen, but the treatment modalities seem to work the same. There's no real difference in the studies between non-selective and COX-2 selective with regards to side effects or with regards to their action. And really, across the board, the studies show that diclofenac is the most effective of the NSAIDs, particularly in knee arthritis. Now, I don't think that's because it's got a predilection for treating knees better than other joints. I think that's just because the studies have been on knees, because knees are more common than hips and shoulders. But I think it's fair to extrapolate that data. Now, the reason for diclofenac being the most effective is in some of the studies and in some of the sort of biochemistry, it's thought that diclofenac is actually deposited into the synovial tissue, so has a stronger local effect at a joint level rather than just its sort of humoral effect from being in the circulation. And there are the obvious renal and GI side effects, which is why we really don't want to be using these as a chronic medication. And particularly in one of the studies, it talked about getting the best results with NSAIDs using them continuously. Now, it sort of flies in the face of what we're taught and what we think is good medicine, because I don't think too many people here tonight would think it's a great idea to just put your patient on an NSAID, leave them on it forever without reviewing the time frame of which they're on that because of these side effects. So probably the most interesting part of this talk, I think, tonight, or particularly when we're talking about the medication aspect of this, and something that I didn't really realize until I did the literature review for this talk, is how good and effective the topical non-steroidal anti-inflammatories are. So the recent data, over the last 2 to 4 years is very supportive of topical NSAIDs. So the results of these studies have really demonstrated that the NSAIDs improve symptom severity, improve daily functioning and quality of life to a significantly greater degree than placebo. But also the results of the topical NSAIDs were comparable from an efficacy point of view with oral formulations. So putting a Voltaren gel on your knee, for example, in these studies, the symptom relief was about the same as taking Voltaren tablets. Now, I'm not sure at which dose they looked at in these studies because they didn't talk about the oral dose. And if we go back a slide and you look at where diclofenac was deemed to be the most effective medication, I think we'd all say that 150 milligrams is a pretty robust dose of diclofenac. And I'm not sure I'd be too happy with my patient being on that for more than about 5 to 7 days. And I definitely want them on a proton pump inhibitor for gastroprotection as well. And I'd sort of want to know about any sort of renal history in those patients as well, because that's a pretty mega dose. Certainly in my hands, it is anyway. So back to the topical NSAIDs. And then if we look at the adverse side effect profile, so on one hand, you've got their efficacy is about the same as the oral NSAID tablets, but then the side effect profile is about the same as the placebo. So pretty amazing. Like you've got the positive effect on one hand, and you've got, very few negative effects on the other. To that end, the topical NSAIDs are now, and I didn't realize this, but they're now the first line treatment recommendation for the American Academy of Orthopedic Surgeons, the American College of Rheumatologists, the American College of Physicians, which is sort of like their GP college, and also the NICE guidelines, which is, a big group in the UK who basically publish their evidence-based guidelines for all the doctors over there. And the NICE guidelines recommend that all patients receive first-line treatment with a topical NSAID before you go to using an oral NSAID. And again, the diclofenac was the standout in the topical NSAID group. And again, we think from a biochemical point of view, it's due to this deposition in synovial tissue that diclofenac has a propensity for above the other types of anti-inflammatories. A much more sort of controversial area is the more nutraceuticals, if you will. Certainly 10 years ago, probably even a little bit more, there was a lot of hype around these. Essentially at that time, they were seen to be precursors to cartilage tissue. Okay, we thought that by giving these medications to people, we're going to be able to regenerate cartilage because we're pumping people up with the precursors they need for cartilage. There's one very big theoretical problem with that, and that's that articular cartilage doesn't have a blood supply. It's avascular. Okay, that's the whole reason we're sort of having this talk tonight around the management, and there's no cure, and that joint replacement is the only option at the end of the day, because in regenerative medicine, to heal anything, you need a blood supply. because the blood supply takes all those lovely growth factors, takes oxygen, takes all of the things we need for healing. Now, if the tissue doesn't have a blood supply, how do these things get there? And to that end, being an avascular tissue and you're taking this medication orally, how does it get to the cartilage tissue? How does it get incorporated in the cartilage tissue? And how does it become a precursor to regenerate more cartilage? Well, the bottom line is it can't if cartilage is avascular. So rather than, our thoughts on this have evolved, and rather than thinking of glucosamine and chondroitin as building blocks for regeneration of articular cartilage, a lot of the studies have more hypothesized and talked about a general anti-inflammatory effect of both glucosamine and chondroitin. And so we probably think it's that anti-inflammatory effect, it sort of has an effect on cytokines and inflammatory mediators that has the symptom improvement rather than any regenerative effect on articular cartilage. So, I mean, broadly, we would have to say that there's insufficient evidence to really recommend either glucosamine or chondroitin. Generally, in the literature that I looked at and in my practice and in my thinking, there's a bit more evidence for glucosamine. Okay, there are a couple of well-done studies that showed improvements in glucosamine, but there are also a couple of well-done studies that showed no difference. So we've got some conflicting data from those trials. I don't really use chondroitin. I think the evidence is lacking for it. But basically my approach with glucosamine is, it's a safe medication. It has almost no side effects. There's almost no overdose potential, and it's not ridiculously expensive. So, I say to my patients, look, give it a try for 4 weeks. Some patients think it's fantastic and it works really well. And you might say that's placebo effect, but I think in trials, you might want to control for placebo because you want to have a look at what's the real effect. I think in practice in medicine, you just want to make your patients better. And so if it is placebo effect, I don't really care. If my patient comes back and says, hey, doc, I feel so much better now that I've been on glucosamine, like my pain is about 30% better, and that's enough for me to function, to go walking, to do all these things I want to do, I'm not going to ask any questions. So I'm happy if they're happy, and that's all I think we need. So certainly the best evidence for this is glucosamine sulfate. There are a number of different preparations, and I don't think they're all equal. So the good data that I found was all glucosamine sulfate, and you had to have a fairly robust dose. It had to be 1.5 grams a day. So if you're going to recommend it to your patients, and I think it's a reasonable thing to do after a conversation with them saying, hey, look, it's a bit of a 50-50 proposition. There's some trials that show it works. There's some trials that show it doesn't, but there's no real harm in trying. Give it a month. If it doesn't work after a month, it's not going to. Save your money and spend it on other things. Opioids, look, there's little doubt that they have a good analgesic effect. We all know that. They're a strong painkiller. They work well in the right settings, but chronic pain management is really not an amazing setting for opiates in any space, in my opinion. And the chronic nature of osteoarthritis really raises significant issues of both tolerance and dependence with opioid treatment. So you might get a good effect at the start, but the reality is, all of these patients are going to develop tolerance. So the dose is going to have to keep sneaking north. And as the dose sneaks north, the risk of dependence goes up exponentially. And so does the risk of inadvertent overdose, and also the risk of patients taking it more for the psychoactive effects rather than purely the analgesic effects. And I think it's well established that people who have been on it for a long time and are starting to develop tolerance also have a higher propensity for abusing these medications and taking it for, as I said, psychoactive effects rather than analgesic effects. So in my practice, I don't use it at all other than post-operatively. And so I definitely use it in patients who have joint replacement surgery because I know that they're going to have severe pain. I know that that pain's going to be short-lived and it's going to settle in the appropriate time as their joint replacement matures and as their pain, post-operative pain settles down. And so, seldom are they on it for more than, 2-4 weeks, and they come off it very easily. So there's an end goal to it. We're not just putting them on it and sort of saying, well, going, this is your management. There's an end goal to the post-operative use of opioids. So that's most of the oral medications, and I'm sure there are other things. There's a plethora of various things. There's turmeric, there's all sorts of things out there, but these are the sort of mainstays that I chose. They're probably the things that have been best studied, and they're the things that there's the most data for. If there's any questions on other things, I'm happy to sort of take them ad hoc, but they're the core sort of pharmacological treatments that I see. So then we move on to injections, and we're sort of going to talk about this on increasing levels of invasiveness, if you will. So the first and obvious one that I'm sure we've all used in patients who have both osteoarthritis and inflammatory arthritis is steroid. Okay, we all know it's a potent local anti-inflammatory. And in osteoarthritis, we can inject it into joints, so we get a really good, strong, high local concentration with few of the systemic side effects that we see with oral steroids. And I'll touch on a few of those, the caveats on that a little bit later. Now, there's consistent evidence of a good effect across multiple studies and many years. The greatest benefit is about 1 to 2 weeks post-injection. And most of the studies show that there's no benefit at or beyond 26 weeks, so 6 months. Anecdotally, and I think you guys will all share this, it works well for about 4 to 6 weeks. It's pretty predictable. It works well in most patients. It takes about 7 days to kick in, works well for 1 month to 2 months, and then they're back to square one. And they're absolutely no better than they were before you gave them the injection. The one thing where you do sometimes see some systemic side effects, I know I talked before about being able to get a high local concentration with minimal systemic side effects. You certainly do see labile blood sugars, particularly elevated blood sugars, in diabetic patients even after a local steroid injection into subacromial bursa or into a knee. So you sort of just need to be a little bit cautious with that. And I always warn the patients, hey, your blood sugars could go a little bit haywire, so just keep an eye on them, and you might have to adjust your medication appropriately. So a medication that I use quite a lot in my practice is hyaluronic acid. So hyaluronic acid is essentially a naturally occurring substance in synovial fluid. In simple terms, you can think of it like a shock absorber. I tell patients, I call this WD-40 for knees with my patients. They understand that. You put a little bit of lubricant in there, it helps things run a bit better. That's the other analogy I use is it's like getting your car serviced. If you drive in with a Holden Commodore, we don't send you home in a Ferrari, but at the same time, this is going to make the engine that you've got run better, feel better, and it's going to improve your symptoms for a period of time. But the same way you need to get your car serviced at various intervals, the hyaluronic acid doesn't last forever either. Now, the literature would generally suggest about 6 months. Anecdotally, I have some patients that get longer, but also anecdotally, you have some patients in which this doesn't really work well at all. But I've certainly got plenty of patients who just literally come and see me every 12 months for their Durolane or hyaluronic acid top-up. They come in, we give them a jab, they go away, they disappear for 12 months. I don't hear from them, and they come back and they literally say, yeah, it's like I can set my calendar on it about 2 weeks before I'm due to see you. My symptoms come back, and then they're well treated with periodic hyaluronic acid injections. The peak effect for hyaluronic acid is at 5 to 13 weeks. So I always tell patients you've got to give this a month or two before it kicks in. So the studies have shown that it's less effective than steroids in the short term because, as we know from going back to the last slide, the steroids have the greatest benefit at 1 to 2 weeks, but don't really last much beyond 4 to 6 weeks. So they're less effective than steroids short term, but much more effective in the longer term. The recent studies have also not just looked at hyaluronic acid or at steroid on their own. And a lot of the initial studies looking at hyaluronic acid, they compared it to steroid and found it superior to steroid, particularly for the longer term effect. But the more recent studies have been looking at a combination of both steroid and hyaluronic acid together and whether that improves the results from these injections. Now, fairly broadly, all of those studies showed it did. And look, to be honest, I've been using it as sort of as an off-label, if you will, indication for the last 8 years. So it just made sense to me conceptually. So you've got two different injections. They work in two different ways, and they have different sort of peak onsets of action and different periods of action. Now, so it made sense to me to hit them with a bit of steroid, which is going to be an anti-inflammatory and reduce inflammation. It's going to work quicker so that they hopefully get some symptom relief within a week or so. It's going to last for about 4 to 6 weeks, which is just around the time the Durolane's kicking in. And then the Durolane takes over and hopefully gives them 6 to 18 months. And we've sort of had a bigger win with that two-pronged attack. And so I don't give them any extra needles. So when I do this, I prep and drape them literally as if I'm doing a surgical procedure. I don't just use an alcohol swab because of the risk of creating a septic arthritis. I then infiltrate local anesthetic. I use a lateral suprapatellar approach. I infiltrate local anesthetic in the skin right down to the capsule and even just a little bit into the joint. I then introduce a sharp 18 gauge needle, so quite a big needle, but they're anesthetized. And I aspirate the knee to take out any synovial fluid in the knee. So I aspirate any effusion that they have. Once I stop getting any more synovial fluid, I leave the needle in the knee and I just twist the syringe off, and I twist on a new syringe that's got the steroid. I squirt that in, leave the needle in the knee, twist that one off, twist on the Durolane, inject that, pull everything out, done with one needle, one pass in. And so I do that quite a lot with patients, and by and large, most people are pretty happy and get 6 to 12 months and come back periodically for more. The other probably surprise packet for me from my research for this talk was PRP, platelet-rich plasma. Again, I do quite a lot of PRP for soft tissue indications, particularly for lateral epicondylitis. I find it works really well for tennis elbow. But, you know, when I was starting to do the PRP again, sort of 8 years ago, the data for osteoarthritis was again quite conflicting. And so at that time, the data certainly for hyaluronic acid was stronger than it was for PRP. So I was doing a lot more hyaluronic acid than PRPs. In fact, I can't remember the last time I did a PRP for osteoarthritis. But again, you know, if we look at all of the studies overall, there is again conflicting data. There are some well-designed and well-conducted studies that show good results, and there are certainly plenty that show no effect. So the more recent studies, however, have shown significant improvements in the PRP group. Now, that could be because of more refined techniques. So we now look at all sorts of different types of PRP, like leukocyte deplete and all these other sorts of subgroup PRPs. So it could be something along those lines. But a really good, well-done meta-analysis from 2021 showed that PRP injections are beneficial for pain relief and functional improvement in knee osteoarthritis. And two other recent meta-analyses, which didn't just look at PRP and did PRP work, they actually compared PRP to the results of steroid and hyaluronic acid. And these studies actually showed that PRP was superior to both of these, both the steroid and the hyaluronic acid. It recommended a course of 3 injections, 1 to 2 weeks apart, which is great because that's exactly what I do for the soft tissue indications. I think there's enough data to show that 3 injections spaced apart periodically give better results. And the studies showed that the best effect for PRP was around 6 months. Okay, so a longer treatment effect than any of the other injectables. So a longer treatment effect than steroid and hyaluronic acid. And so, you know, whether this is now going to supersede those other injections because of its longevity is yet to be seen. And then it throws up the next question for me that it threw up anyway was well, can you combine PRP with your steroid and your hyaluronic acid? And then you've got a stepwise, duration of effect from, kicking in at 7 days with the steroid. The hyaluronic acid takes over at about 6 weeks. And when that's wearing off at 6 months, the PRP kicks in. So who knows whether that's a plausible, treatment option, but that's certainly what it raised in my head. Look, again, the surprise things for me coming out of this tonight were the really good effect of the topical NSAIDs and the sort of renaissance of PRP and the new improved data and results that we're seeing with that. I think one thing that's probably hasn't changed over the years is the data for stem cells is still not there. It's based on the regenerative ability of stem cells. So, we all know what stem cells are. They're pluripotential. They can go down any cell line. It depends on the tissue they're surrounded by. So the theory is you inject them into a joint, they're surrounded by cartilage tissue, they become cartilage tissue. Now, there's no study that exists that has demonstrated this theoretical regeneration in vivo. So I remember one study in PRP where they injected PRP and did MRIs on patients down the track, and they reckon that there was an increased cartilage thickness. I think it was minimal, and I think it's very difficult because of the inter-observer variability. But there's certainly no study I'm aware of, and I've looked at it fairly extensively, that has shown any regenerative capacity in patients. The studies that have been positive or shown a positive effect have been fairly low quality studies. So there isn't really a strong body of good quality level 1, level 2 study data to support stem cell use. And it's very expensive. I've had 1 or 2 patients who have insisted on going down to Brisbane and get stem cells. And, by the time they've traveled, stayed down there, had their follow-up, done everything, they've parted with about $15,000, for that episode of care. It's about 10 grand just for the treatment, just for having the stem cells injected. By the time you've had 2 or 3 trips to Brisbane, you've stayed there for the best part of a week, the ancillary costs, take it up to about 15 grand. And so if it cost, $150 and it was a little bit, here or there, then I'd probably say to patients, look, if you really want to give it a go, but it's a 50-50 proposition and maybe a bit of a throw at the stumps. But, when it's costing patients $10,000 to $15,000, there's certainly not the evidence to justify that cost and the use of this therapy in daily clinical practice. So then we come along to the non-pharmacological treatments, and they're all fairly tried and true things that I'm sure you've all heard of. And the main things I'm going to talk about are physio, weight loss, bracing, and a newer technique, radiofrequency neurotomy, that's been around in pain management for quite a long time, particularly for the treatment of facet joint osteoarthritis and low back pain. And there's a new sort of more refined device available now. It's called cooled radiofrequency. And it's now lent itself to treatment of the hip, knee and shoulder for osteoarthritis. So physiotherapy and exercise, there's consistently good high level evidence for a positive effect from both of these modalities. It's well established that physical activity and exercise therapy reduce symptoms and improve physical function in patients with, again, knee-OA, but I think it's very easy to extrapolate that data to osteoarthritis in general. More specifically, the literature would suggest that if you do 150 minutes a week of moderate intensity aerobic exercise, and that's not a huge amount, or 2 days a week of more vigorous physical activity. So one might be a brisk walk, would get you into 150 minutes a week. And the moderate to vigorous might be, a strength training session down at the gym. So if you do one or the other of these 2 activities, that they've shown significant beneficial effect in patients with pre-existing knee osteoarthritis. And a lot of the other studies I looked at really talk more about the strengthening component of these exercise programs in benefiting patients with knee osteoarthritis. But the obvious other beneficial effect from regular aerobic exercise is weight control. So a lot of our patients who get osteoarthritis, they get painful joints. The first thing they do is they become more sedentary. As soon as they become more sedentary, they put on more weight. As soon as they put on more weight, they become more symptomatic. Then they become more sedentary. Then they put on more weight. Then they become more symptomatic. And then they get into this vicious downward spiral that to be honest, most patients find it very difficult to get out of. So the difficulty with physio and exercise is patients have got to get off their backside and do it. And so a lot of people want a magic bullet. They want a cure. They want, what can you do for me? Oh, exercise. No, come on. Like, no, what can you do for me? Like, give me a tablet, give me an operation, give me something that's going to fix me. Not tell me what I need to do for myself to fix my chronic illness. And probably the biggest one under that umbrella is weight loss. So there's lots of studies looking at weight loss in osteoarthritis. And again, most of the data is from knees because it's just the most commonly affected joint, but fairly broadly across the board, the data is pretty compelling that weight loss improves symptoms, okay? Now, weight change directly affects the risk of developing knee osteoarthritis. Now, I found this a pretty interesting stat. So if you are a female and you're a little bit overweight, 25 BMI, that's not massive, and you lose 5 kilos, then you are 50% less likely to get knee osteoarthritis. That's a pretty big reduction factor for not a huge amount of weight. And so that's pretty compelling evidence that more and more osteoarthritis of the lower limbs in our current patient population is probably preventable with maintenance of an ideal weight through critical years where patients are loading their knees. So there was this pretty good meta-analysis that showed in adults with mild to moderate knee OA. So the last set of data looked at patients who weren't symptomatic, who didn't have OA, but if they dropped that weight, they were 50% less likely to get it. Now we're looking at what's the effect of weight loss on patients who have established knee osteoarthritis. And so we're looking at higher BMI ranges here, significantly higher. So if these patients with early osteoarthritis and in a BMI range of 33 to 36, if they lost 5 to 10% of their weight, they would have a significant improvement in their pain, a reduction in self-reported disability, and an increase in their quality of life measures. I mean, the simple thing when it comes to weight loss and osteoarthritis is the data is compelling. The translation of this into practice is difficult. And I'm sure we all have the same experience. And then, the difficulty in the patients I see is most of them have already been symptomatic for a number of years. They've tried a lot of the non-operative measures and they've sort of been referred on to a specialist. So by the time they get to me, weight loss is almost impossible in these patients because their disability is at a level that they just can't exercise. And whilst diet is a really important factor in these patients, most of them can't just lose weight with the diet, whether that's a compliance issue, whether it's just because it's too difficult. There's no question that the studies all show that the combination of diet and exercise is by far and away more effective than either of those on their own. So another one that's probably not a bit underutilized in our community, but is very effective is bracing. The issues with bracing are, compliance, they're cumbersome, they're annoying, they look silly, patients don't like them, they don't want to wear them outside their clothes, all those sorts of things. So broadly, there are two types of braces. There's what we call an unloader brace and a support brace. So an unloader brace is more of almost an orthotic type brace. So in simple terms, it corrects biomechanical alignment. So the vast majority of patients, and again, this is more for knee arthritis, you don't really use braces in hip or shoulder arthritis, but the vast majority of patients who present with knee arthritis, the common garden variety knee arthritis is varus malalignment, predominantly medial tibiofemoral compartment osteoarthritis, which then progresses to lateral and patellofemoral OA. So particularly in the early stages, the unloader brace essentially is a valgizing device. So it's an external realignment. Okay. So basically this brace pushes these patients from varus into relative valgus, and the sort of method behind that is most of these patients have a relatively normal lateral compartment with regards to chondral thickness. And so if we can transfer the force out of the arthritic medial compartment and into the relatively normal lateral compartment, we're going to take the load off the symptomatic medial compartment and we'll get rid of symptoms. And look, it works. There's lots of studies that look at these, and the right unloaded brace fitted appropriately in the right patient definitely improves pain, improves function, and delays the requirement for total knee replacement surgery. The problems are they're cumbersome. Some patients get skin or pressure issues because these braces do put pressure on the skin. By virtue, that's what they're designed to do, because they're trying to realign the knee. So some patients find them uncomfortable. They are pretty costly. For a proper real deal unloader brace, you're looking at anywhere between $1,000 and $2,000, and they really need to be appropriately fitted, because you need to have the right size. It needs to be in the right spot. You need to show patients how to put them on, because again, they're realigning patients' knees. So all of the different arms on the brace need to be in the right spot to apply the right pressure to the right area to realign in the appropriate fashion. Support braces, I mean, they're quite simply the off-the-shelf things you get from the chemist. The neoprene wetsuity thing. They provide a bit of compression. They provide a bit of warmth. They don't realign anything. Look, there's limited, hard evidence for these for clinical effect, but there's little to no side effects. And basically for patients, if it works for them, go for it. Some patients feel more comfortable with them on. It gives them more confidence, whatever it is. There's no hard science for it, but if it makes them more comfortable, then by all means go for it, because they're not ridiculously costly, and there are very few negative side effects. So probably one of the more exciting things that I think that's come along in the last 8 years of my practice is this intervention called cooled radiofrequency neurotomy. You've probably all heard of radiofrequency ablation of sensory nerves to joints for in other conditions, particularly in the management of chronic lower back pain. So cooled radiofrequency ablation is basically the same as traditional radiofrequency ablation, except there's a water cooling system that runs through the probe to the tip of the probe. So water that's at room temperature is circulated through an isolation channel around the electrode tip, and it creates continuous cooling of the needle tip. So as a result of this, the procedure produces a much bigger ablative area. You basically can extend the zone of damage, and you can heat the tip of the electrode up a bit more because of this water cooling. So you extend the zone of tissue damage further. So you're more likely to capture all of those sensory nerves around a joint because it's a bigger area. Whereas when you're just targeting a facet joint, it's a much smaller nerve, much smaller area. You don't need that sort of spread to make sure you've captured all of the sensory fibers of the joint of the nerve. So essentially, the cooled radiofrequency, the theory behind it is you're more likely to be successful in a big joint like a knee, a hip, or a shoulder than you are with traditional radiofrequency, which is much more adept to a really small, tiny joint like a facet joint in a back, which is, the size of a pea, if that, versus, a big joint like the knee. So basically, it's a day procedure. It is procedural. So technically, it maybe isn't non-operative, but I put it as a procedure rather than an operation. So it's a day procedure. People come into the hospital, and we do it under either sedation or a light general anaesthetic in the operating theatre. It's percutaneous needle placement under X-ray control. So these needles are no bigger than an intravenous cannula that you put in a patient to give them fluid. They're hollow like an intravenous cannula, these needles, and we place, so for example, for the knee, we place 4 of them around the genicular nerve branches, which are the sensory nerve branches for the knee joint. And we place them under X-ray control, and basically we use the image intensifier to put the needles into particular landmarks where we know from lots of anatomical and cadaveric studies these genicular nerve branches run. And they run right on bone, right next to the joint. So we touch these needles against the bone in the predetermined places. And once we've confirmed the position of the needle in two planes, so AP and lateral, we then fire an electrical stimulus down the probe. So we put the probe down the center of the needle. We fire an electrical stimulation to ensure that we're not touching a motor nerve. So obviously with that electrical stimulation, if we're near a motor nerve, we'll see the muscle contract on the operating table. So we fire the electrical impulse, and if we don't get anything there, we then hit the button on the radio frequency machine. That then generates a radio frequency signal that goes down the probe. And that, in simple terms, it heats the probe up to 60 degrees. And we leave it heated for 2.5 minutes. At the end of the heating procedure, I then take the probe out. I inject 5 mils of local anesthetic down the needle. So in addition to thermal damage of the nerve, they're also getting a nerve block. There's literally no downtime. And it's about the only procedure I do or have ever done in the operating theatre that has no downtime. Everything else, yeah, there's a greater good at the end, but there's a post-operative recovery, okay? Even a knee arthroscopy, for a couple of weeks, patients are slow, and they've got to get better down the track. Patients walking out with less pain than they walk in with this procedure because they've just had a nerve block, okay? And so I've had some patients who just like think this is magic, like, oh my God, I'm cured. Sort of temper them a little bit and say, hey, look, it takes 2 to 6 weeks for the treatment effect of the thermal damage of the nerve to kick in. And you'll probably get a bit more pain, over the next couple of days as the local anesthetic wears off. But it's a very effective treatment for getting rid of, in the literature, we would say about 80% of pain. And it lasts between 1 and 2 years. And lots of data now coming out showing that if a well-done radio frequency neurotomy, where you've got your probe appropriately positioned, will get 2 years of pain relief. And if patients get a good effect, it can be repeated. So if you've got a patient who gets a really good response to an RFA, and 2 years later, they're like, oh, doc, my symptoms are coming back a little bit. Well, there's 2 conversations. Okay, yeah, your disease has progressed, time to do a joint replacement. Or, if you really want to kick the can down the road a little bit and sort of not go down the line of a joint replacement, we can have another go at your RFA, and you should be able to get just as good a result for another couple of years. So, I mean, the studies on this show that there's significant improvement in pain relief and in overall function. And the recent data has used the comparison or the control arm, if you will, has been a single injection of hyaluronic acid. Okay, so these groups of patients that had failed other non-operative treatments, and they came along and they were randomized. One group got a HA injection, the other got called RFA, and the RFA group had significantly better outcomes than the HA injections. Those outcomes were significantly greater, so better pain relief and for longer. They had better improvements in their physical function and also higher patient satisfactions. And in that study, that was compared to steroid injections. It's very safe and well tolerated. I mean, theoretically, yes, there's a risk you can damage other neurovascular structures, but with the adequate training and adequate placement of the probes and the electrical stimulation, all of those negative side effects are really at a minimum. And this study down the bottom, which I really thought was pretty pertinent, is these people looked at it from a health economics point of view, and they studied, the potential costs for these patients having other treatments. So whether that be medications, other sort of interventions, and even arthroplasty surgery. And they showed that cooled RFA in patients with osteoarthritis of the knee was a highly cost-effective treatment option. So, I mean, in summary, it's a fairly new treatment modality for the hip, knee, and the shoulder. Obviously, it's an extrapolation of traditional radio frequency for facet joint pain in the back. The recent literature shows excellent results. The recent literature also shows little to no side effects. Excellent pain relief has been achieved in most patients. and a treatment effect of years. So, previously we've been talking about weeks or months in most of the injection cohorts, but now we're talking about years in this procedure, which effectively has no downtime either. It is essentially an injection. We're putting needles in and we're burning through those needles, but there's no incision, no tissue trauma other than the thermal damage to that zone of injury around the nerve. So these patients can literally go back to normal life the next day. Obviously, in an appropriate patient with appropriate symptoms, joint replacement surgery is still, the gold standard. It's definitive, it's curative, it's long-term. But in my hands, I think cooled RFA is a really good option in young patients. I'm sure we've all seen patients who are in their 40s who've had, ACL reconstruction surgery that maybe wasn't that successful. They've had a meniscectomy, that have now got really severe post-traumatic osteoarthritis, and they're debilitated. And I think it's a great option in those patients where we don't want to do joint replacements. We've exhausted all other non-operative measures. I think cooled RFA is a bit of a game changer in that patient population. The other patient population is the crumbly old patient, or the crumbly patient with really severe medical comorbidities who's not fit for a haircut, let alone a joint replacement. And so we used to have to tell those patients, sorry, there's nothing we can do. You just go home and live out your life being miserable and in a lot of pain. And I think it's really nice to be able to say to these patients now, hey, there is something we can do. It's not going to cure you, but it's going to make life a hell of a lot better. And we can do that for you because it's a really low risk procedure. The other patient groups are just patients who want to delay joint replacement surgery. Like, I get lots of patients who are like, yeah, look, doc, I know I need a knee replacement, but I can't do it now. I don't have the time. Work's too busy. I'm retiring in 12 months. We've just bought our caravan and we're going to do the round Australia trip. Is there anything you can do that can just, get me, a bit better pain relief and quality of life for the next 6 or 12 months, and then I'll come back and see you for a joint replacement when I'm ready. And I think this is a great stopgap to offer those patients, in that sort of interim period. It's not curative. It doesn't change the disease process. I'm very sort of specific with patients about that. It doesn't alter your disease. It doesn't cure your arthritis. Basically, the sort of analogy I use is it's like putting a blindfold on your brain. Your joint is exactly the same joint as it's always been. Your brain just doesn't realize it's painful anymore because we've stopped the pain signals getting from the joint back to your brain via the nerves. And on that note, it's purely a pain management intervention and nothing else, but it's an effective one. It's a very low invasiveness procedure with a very quick recovery. And I think it really serves a big gap in the market that we had for managing these patients between, sort of doing nothing after the exhaustion of non-operative treatment and joint replacement surgery. I think that's all I had to talk about, which is probably good because after an hour on a Tuesday night, after a long day at work, it's probably all you guys are up for.
Okay, so has anyone got any questions for Glenn?
Sure. And is there any questions?
Yeah. Don't be shy.
Everyone's gone to sleep.
I think you just covered everything, Glenn. It was a fantastic presentation, very inclusive. So,
any questions from anyone?
Gentlemen? Nope. Thanks, Bo. All righty. Well, if we've got no questions,
that's it then, Tina.
That's it. Well, thank you so much for giving up your time. I know you've had a really, really big day. So it's very appreciated. And thanks to you all for joining us. I'm just going to launch a quick poll. If you could take a few minutes just to fill it out for us.
Tina?
Yeah. Yeah. Can you hear me? You there? Hello?
It's like everyone's.
You there?
Oh, there you are.
Can you hear me?
I think you're on mute, Tina.
Oh, I shouldn't be.
Oh, there you go. I got you now.
You there?
Yeah, sorry. I had my sound off.
All right. So thanks everyone for joining us. Thank you, Glenn. I know you've had a massive day. Guys, if you could just fill out the poll for us, we really appreciate your feedback because we're trying to make sure that these are meeting your needs in the GP world. And that's all I've got to say. So thank you.
Now, were there any questions? I think I actually had the sound on my computer turned off because my phone was going off and it was beeping on the computer. So I turned my sound off. So I may not have heard if there are any questions.
No, we actually haven't got any in the chat. We've got lots of thank yous and we've got some really positive, strong poll results. So you've done a great job. I think, oh, hang on. Well, we have one question. How does cost compare to HA injection?
Yeah, so the thing with HA injection is it's done generally as an outpatient. So mostly none of the health funds will cover that. So it's a complete out-of-pocket expense. So look, it's probably a little bit more expensive to have the RFA. I presume it's the RFA they were talking about compared to the HA, but part of that expense will be covered by both Medicare and a health fund because it's an in-hospital procedure. Medicare will cover whatever it is, Medicare and your health fund will cover about half. So by the time your health fund and Medicare cover it, they're probably about the same amount out of pocket for a patient.
All right, sounds good. All right, any other questions? Does that cover it for you, Michael? No response. Yep, everyone's happy. All right, Glenn, go and have a well-earned break.
Fantastic.
Busy day.
Right, thanks everyone for coming along, and thanks Tina for organising it. Appreciate it.
Good night, everyone. Thank you. Bye.
Bye-bye.